Welcome, everyone. This is the Startup Lounge. Thank you so much for joining us. As you already know, this is a third episode, and we are glad to have all of you. We are going to have on the set. Yes, hi, Veronica. I can see you. Nice to have you. Yeah, nice to have everyone as well. We are so excited. And today we are talking health and innovation. So we're going to be having one gentleman all the way from Nigeria. So we are really excited to have actually a tech startup from Nigeria, Dr. Debo of Doctora. As we always know and as we always advise, let's just all of us go be on mute, use the chat as much as possible, and also put off your video so that we only have the hosts, co-hosts, and as well the person we are interviewing or we are having a discussion with, I would say. All right, so this is me, Sammy, one of your co-hosts. I'm going to just hand over to Kelly now. Kelly, you can start. Over to you, Kelly. Thank you all for joining.
Thank you very much, Sammy. Hello to everyone. Welcome to our third edition. Like Sammy said, we would like to encourage everyone to drop video. This would be recorded and shared with you later on, so you can listen to or share with other people who are not on with us today. All right, we are going to have an interaction with Dr. Debo Odolana today, who is an entrepreneur from Nigeria, the founder of Doctora. So without much ado, if Doc is on with us, I want him to say hi to everyone. Hello, Doc. Are you on with us?
Hello, everyone.
Hello. Hi.
And thanks for the invite. It's really a great honor to be here with you guys.
Yeah, it's an honor to have you too, Doc. And I'm sure it's around 6 p.m. in Nigeria now. So I'll greet you by saying Ekru Oleo.
Yes, thank you. That's how you say it in Yoruba, yes. Yes.
All right.
Yes, that's how you say it in Yoruba.
Kelly learned some Yoruba. All for you.
All right.
Yes.
Awesome.
Sorry for the late listening. I was looking for some perfume, you know. So we can ask.
Yeah, that's understandable. All right, so Doc, I'm assuming you've had a good day today. So taking it from there, I would just want you to share with us what a typical day is like for you, a medical doctor as well as an entrepreneur. Can you share briefly with us how your typical day is like?
Well, it's not as exacting as it probably would look. Currently now, because of COVID, mostly working around COVID-related things. So trying to juggle the business with contributing my skill sets to the overall national response. I also manage the technology for one of the isolation centers here in Lagos. As far that's the only center that actually has any, should I say, healthcare technologies per se being in use. Yeah, there's some healthcare equipment, but we're talking about EMRs and the record. I kind of just generally keep the business active because I would also be getting some requests from patients, trying to contact some doctors to remind them about their appointments and things. So it's a bit tough, especially since before COVID, I would typically have had a bigger and wider team to do that. Because of COVID, we've had to kind of make some cuts, and that has kind of put the work on me, myself, and the other members of the team.
I see. Typical life of an entrepreneur, and it's
Yeah,
actually
you
been
just have to
compounded
kind of
by the COVID situation. So thank you for that. And we will just zoom straight into yourself now. If you could tell us briefly who you are, who Dr. Debo is, your education, as well as why you decided to find this new love with entrepreneurship after being a medically trained doctor.
Okay, so I'm Debo Odulano, Nigerian, Yoruba. I grew up in Nigeria up to secondary school and A levels. After that, I went to Dubai for my medical education. Going to that country made me realize that we're really a way behind in healthcare as a country. And I started to think about ways to contribute to improving healthcare in Nigeria. And that made me realize that I couldn't really do that as a clinician, that I would need to really consider stepping out of being a clinician to do that. I learned this when I first came in during my 4th year of medical school for a training program in Lagos. And it was a mess. So my mentors at the time advised that if you're going to come back here, you need to really rethink what you want to do as a professional. The other thing was, at that time, I wanted to be a neonatal surgeon. I don't think we have more than 10 of those in Africa as a whole. And that is just generally because we don't have the kind of equipment and the type of facilities and type of support staff that those guys use for their procedures or their services. So me trying to do that in Nigeria, my mentor was saying to me, hey, there's no facility, no incubators, nothing. How are you going to have a good practice? So that got me thinking that, okay, why don't I forget this career path and go on ahead to create a solution that will solve these problems that are affecting professionals like neonatal surgeons from being available in the country. And that made me start to probe into it. So I moved back to Nigeria and worked for 7 years. During those 7 years, I gained experience at the state level, working in an urban setting, in a rural setting. I'd also gained experience working at the private hospital level, working in an urban setting and a rural setting. So kind of I've gone round and understood the gaps in the system. And the major gaps that stood out were infrastructure and workforce. So we don't have enough workforce because people just can't bear it here. So they leave to better countries where they can get better salaries. And they also struggle to advance their careers because there are not a lot of training opportunities. Like I said, if someone else wanted to be a neonatal surgeon, he needs to move to the US, UK, or Canada to do that because they don't have enough training programs in Africa, right? So my naive self, my plan was that, you know what, why don't you go create a neonatal surgical center and then offer it to the government so that you can get your own training done at that center. So it was just a really sort of selfish plan initially. When I got into it and the technicalities of actually setting up centers, I realized that I've stepped too far away from a clinical career now. And going back in the future, even if I get that authentication for a residency program, I don't think I would be a candidate to be able to even ever get into such a program again, right? But the end point was, you know, seeing that the problem was infrastructure and workforce. Workforce could not make enough money to build infrastructure and set up their own private practice and make more money, so they leave to other countries. Infrastructure is not going to fix itself. It needs money. Investors are not going to invest in infrastructure if they don't see that the infrastructure is bringing money. And then the people who are going to pay money to use this infrastructure, the patients, are not exactly very buoyant financially. So over 90 million Nigerians, for example, spend less than $6 a year on healthcare. So if that is the demand for healthcare because they don't have insurance, then we really are not doing anything. So the market failure was not on one side. It was on every level of that value chain. So again, what was meant to just be a plug and play solution of, oh yeah, we will set up some facilities and we will provide a tech platform to allow those people rent these facilities, now turned into a whole, you need to build a private healthcare system or a private healthcare network of your own from scratch. Because the doctors just wouldn't make that cultural shift. They wanted to understand, why am I going from what we're used to, which is private hospital A needs me to come and do a surgery for them. They tell me how much they're going to pay. I run there. I take some peanuts from there. I learned a bit more about technology management and how to introduce it in the sort of greenfield sort of opportunity. The downside was that my co-founders were part-time and they were not even based in Nigeria. So it was a case of, hello guys, there's a really great idea, great opportunity in Nigeria. I'm gonna go back home and start working on it. If you guys are interested, you can join me on it. Yeah, we're interested, we're gonna join you on it, but we can't come to Africa. And hopefully that issue will be resolved soon. So that's how it's really started, and how we got to this point. It was based out of a need. Facilities in Nigeria are not so great. The ones that are great do not make a lot of money because Nigerians are not actually, majority of Nigerians cannot actually afford quality healthcare services. And because of that, the demand on for professionals is also low. Professionals get paid low, and all of that cascade keeps going up. Yeah, and we're just trying.
I love the fact that you've been able to touch a lot on what the systemic problem is, and I can attest to that. In my little research before today's engagement, I realized that yes, Nigeria is a very huge economy, in fact, the biggest economy on the continent. But when you narrow things down to the health sector, it's not performing too well. If you look at statistics like doctor to patient ratio, things like life expectancy. In fact, there was a work done by WHO, I think some years back, that ranked Nigeria 187 out of 191 countries, when it comes to healthcare system. So it looks clearly that you have some issues there. But before we run ahead of ourselves, what I want us to do and what I want you to do for me is now carry our audience along with you and tell us specifically what Doctora is about. You've touched on the problem, infrastructure, and then workforce. Now tell us what Doctora is and which aspect of this challenge are you trying to solve and how are you doing that?
Okay, thank you very much for that question. So essentially, like I discussed, we saw that the market failure was on different levels, but we had to figure out which level was the most crucial. Again, we saw another issue. Nigerians, I just said that 90 million Nigerians, over 90 million Nigerians spend less than $6 a year on healthcare. So those guys, for example, now, they're not really contributing to demand. In fact, they're a burden to the healthcare system, right? Now, you can now imagine that another 50,000 Nigerians, on a yearly basis, spend $1.3 billion on healthcare outside Nigeria, right? And that is also because they don't trust the healthcare system. Another result of market failure, right? So if you really have any industry where you have a serious market failure, trust now starts to set in, right? So that's a big issue with the Nigerian system. So you see people traveling to India, traveling to the UK, Germany, and the likes for medical treatments that they can get in Nigeria. So the people that have the services are not able to sell services because they are facing competition from international competitors. And then they cannot also reduce the price to sell to the lower
cadre of the market, because that little kind of market, the profitability margins are very low.
No.
So we felt infrastructure is the major issue that people look to when they are trying to ascertain trust in healthcare, right? So as a lay person, the difference between, before you know whether the doctor is good, or you try the medication or try the treatment plan that he wants for you, the real thing that makes you feel like, oh, I'm in the right place and I'm going to get good healthcare is the ambience, the environment, the way that it looks, the reputation, the feel, right? So we felt if we can fix the infrastructure problem, then it won't be hard to say to an Indian doctor, hello, we realize that a lot of Nigerian patients are coming to India to see you for so-so cases. We now have the facilities to do those cases in Nigeria. Why don't you fly into Nigeria to do those cases instead? As opposed to a lot of Nigerian patients coming with their family members and all of that to India to do that. If you fly to Nigeria, then it might be just you and your team, and we solve this problem. So we started to get some traction from those Indian guys that they wouldn't mind doing that. So that informed our decision to become an infrastructure as a service company. So essentially, what Doctora does is that Doctora provides rentable medical facilities and software tools to healthcare professionals who are interested in starting their private practice or running their private practice. With this, they can establish private practice without incurring setup costs, and they can also roam across multiple locations, and in the future, I hope, roam across multiple countries without having to bother about those costs. So essentially, I would use some example. Sorry, I was lucky to be in Accra for a bit last year. But if I was in Osu and I was a doctor based in Osu and I was getting a request from a different region in Accra, I could essentially just find a clinic or a theater in that region, if it was a surgical case, that I can rent for an hour, for a day, for 5 hours as needed to be able to see that patient in that region. So doing that, I am now like essentially like a Uber doctor, or a doctor who just runs his private practice as needed. In addition, these doctors now have teleconsultation fees, tools to say, if I saw that patient and I've gone back to my my base in Osu, and that patient requires a follow-up because he has done his test and the results are out, then I don't have to travel all the way again. I could just schedule a follow-up visit this way via video call to discuss with the patient, and that is closed. So those are the kind of things that we do as a company. We have also added an inbuilt EMR to our platform to enable these doctors move from place to place, and also carry along their patient information records and all of that with them. Our ultimate goal, like I said, is that if we can reverse medical tourism, then we're going to be able to capture a bit more money and expand the effective demand for healthcare services, which will in turn invite more investors to invest in healthcare, and that will generally improve our healthcare system. Again, we can't do it all. We just want to show a model that works so that a lot of people can try this model and we can expand capacity in that way, right? The essential thing in healthcare is that if we can create effective demand through insurance or any other scheme, just by making sure people pay for this healthcare, then service delivery and service provision would not be much of a problem. But if people are refusing to pay, in Nigeria, for example, insurance wouldn't work so well because insurance is meant to be a sort of James Bond, Robin Hood sort of model, right? So you take more from the richer people who are less likely to consume healthcare and use it to cover because you're taking little from the poorer people who are more likely to consume healthcare. Now, if the poorer people put their money into insurance scheme or donor funding, so pays for them, right? But the richer people are taking 1.3 billion US dollars every year to other countries, then that insurance is not going to work because there's no money in the insurance pool to cater to everybody's fees. So the more we can convince those people to keep their money here, the better for us.
The better for the system. Yeah, that's amazing. This is a very exciting model, and I think one thing that's great about it is that because of how similar the problems within the health sector is across the sub-region, this is a model that I think can be replicated once it is tested quite well. You did indicate that this largely runs on infrastructure, and I'm sure you've still not gotten your head around it fully yet, because irrespective of the model you are running, you still need the physical infrastructure anyway and accessibility to it.
Yes. So
talking about that, my colleague Samuel would want to come in with a point, and then you just add that to what you want to say now. So Sammy, you can come in now.
Thank you so much, Debo. I think your explanation is really vivid and it's really cool. One thing, when you're talking and I was listening to you, I see clearly that like the main person you're targeting are the health practitioners, right? But I also see you can actually see there's also that part of it where the patients themselves somehow become as well, like the Uber model, like the person who is getting the also is a customer, and even the driver is also a customer. Is it like that for your kind of model as well? And do you pay attention to them? But
so we essentially have three major customers: the facility owners, the health professionals, and the patients, or the patient buyer, right? So the patient buyer sometimes is now the insurance company because they represent a lot of patients, right? So that's essentially what we do. But we know that the most important person here is the health professional. If we provide the right environment for the health professionals, then the patients will get satisfied. The facility owners will also get satisfied. So a bit back to our model, it's really focused around physical infrastructure. We noticed two problems when we looked at the infrastructure. One, there isn't enough infrastructure, meaning we don't have all what we need. Two, the existing infrastructure is severely underutilized. The busiest centers do not use more than 60% of their existing capacity.
That's very true.
So we started with how do we aggregate this existing capacity across multiple sites, such that we don't just jump in and put a capital into setting up new facilities. When we take up this existing capacity, we are able to rent it out to the doctors that need it. So in this scenario, we are the middleman. We just connect the facility owners as a customer to the doctors. Now, we'll now go to the other end. The doctor needs demand to be able to pay to use the facility. So we also do some marketing to the patients and to the HMOs on behalf of the doctors. Ideally, the doctors should really do this themselves, but we're in Africa and our doctors have not been trained to do anything business. They are very egocentric. Sorry, I'm one of them. So they're very egocentric.
You're free to say it.
We are difficult. We cannot be trained. And there's a lot of stuff. So all of that together made us realize that no, if we can provide the demand for the doctors, then they are happy. All the Nigerian doctor really wants to see is that, hello, there's a booking for you, the patient has paid. And then they do their own stuff. It took us a while to understand that is the barest minimum that they want. We thought that, oh, guys, we give you this, and then that doctor is going to go and say, yes, and now I have 30 facilities I can use. I'm going to tell everybody in my church, I'm going to do this. They won't do anything. Then they're just going to wait till you send them money and tell them there's a patient waiting for you. Okay? So yeah, we are now at the phase where, as a company, we are now looking to introduce new infrastructure.
Yeah.
And we're doing this based on gaps,
Mm.
and gaps that people don't really know that they need. We have a different approach to infrastructure. I personally don't want to delve into any type of infrastructure that we cannot drive utility beyond 80%.
Yeah.
And that limits us to a lot of to a little pool of infrastructure. So we're now looking at elderly care homes.
Yeah.
I know with our African scenario, a lot of people still think that elderly care homes might not be a very good idea here, but I think very contrary to that. Why I think contrary to that is more than 80% of diaspora remittances are actually for elderly care, and more, out of that elderly care remittance, a significant component of it is actually for accommodation and day-to-day care. So if you're able to bring those people together, about 30 of them in a very nice bungalow estate, with enough people to care for them, those diaspora people will pay for their parents back home, but they guarantee that some medical guys, well-trained, accountable guys, are catering for their parents, right?
No.
So yeah, so as long as I'm not trying to do 5,000 beds, 10,000 beds of the early care center, and we're saying the population of the world of our countries are within certain limits, and I'm doing little numbers of 20, 30, 50 at maximum per location, then there's a good business around that. The other part is highly specialized medical services. So, the way we've structured our health system in Nigeria, we are more inclined, and this is similar to other African countries, and this is generally an old way of thinking around healthcare facilities.
Yeah.
But we've been setting up a lot of one-size-fits-all mega hospitals, and those things don't work anymore, right? Mega hospitals are good for, those nice commissioning where you go and cut the ribbon. But beyond that, they're just a complex nightmare. Now, we are of the opinion that if we take and we decide that, what we want to achieve in Lagos is that by the end of X period, we want to have a total of 28 or 30 surgical theaters. Those 30 will be in all of these partner facilities that we have. But we want to set up a high volume surgical care facility that any of the cases that are of considerable volume that are coming from our referral sites will be sent in there. Now, what this helps to do is to help us to achieve economies of scale, right? So the typical scenario is most people want to build a hospital that has cardiac surgery, neurosurgery, dialysis, medicine, this, and then you end up with 160 beds in one location, a lot of equipment, a lot of expenses, a lot of overheads, and a lot of people who have to travel long distances to come and receive care there, right? And that just makes sure that it doesn't work. So if we decentralize it, and we know that we just have a lot of small satellites with 10, 15 beds scattered all over, and we have one center that maybe has 50 beds and an ICU with 4 operating theaters, there's so much we can do. We can have 2 days a week for cardio, 2 days a week for ortho, 2 days a week for another specialty, and that way everything is moving smoothly. I don't know if you guys are getting me.
No.
Awesome. I get it. And Doc, I want to come in here. I want to come in here. Yeah, I love the point you're making. This is taking us deep into how your system works and how you aim to address the problems. But I want us to run a bit quicker. We've done about half an hour so far.
Half an hour.
We have just about the same time. Yeah, we have just about the same time to go again. So just quickly, I would want to know, based on everything you've said, how far have you reached now? I was watching an interview you granted whilst you were part of the Make IT program and said that, and this was in 2018, you said in a year you were aiming to at least reach 6 states in Nigeria.
Yes, so we've done 3 states in Nigeria. We again
to states, how many do you have and all that?
Okay, so we've done 3 states in Nigeria. We have 30 facilities on our network now. 300 doctors now as at yesterday, and we've also gotten 88 facilities on our wait list. So what we are waiting to really expand to other states is traction from the health insurance companies, because they have the greatest amount of demand. The issue with that is that no health insurance company is going to give you a considerable volume without asking for something. So that discussion is long. But we're hoping that will get by. The typical scenario is we're saying, hello, health insurance company, we can do services cheaper than what your hospitals are doing. If you send us 20,000 out of your 50,000 lives, then you'd make X amount of cost savings. And then the insurance company is like, oh, great, that's so good, but you guys will be making so much money. If we are not on your board, then we really don't feel obliged to really push you this volume of whatever. So they want some stake and they want a board seat, you know? So those kind of little things are the things that, I don't know if I would say they stifle innovation or they build it, because I know InterSwitch, which is which is perhaps the real unicorn we have in Africa, exactly. Was set up in a similar way. Where the bank said, hey, we can't use you as a switch if we're not members, owners of this. And then they said, okay, no problem. Why don't we create a new company? And all the major banks would have a stake and everybody would create an agreement. So we're trying to do something similar like that for the healthcare setting.
Awesome.
To kind of just add to the other question you asked, sorry, I think someone that's just, I saw it pop up. It wasn't you, someone that asked. Yeah, revenue model. Our revenue model is mostly rent. So from between the doctors and the facility, the transaction there is rental. If the facility belongs to us, we take it all. If it's a partner facility, we charge a percentage. Then the other end is between the patients and the doctor. There, the model is booking fees. Those are our core revenue models. We have some other things here and there.
Yeah, and don't worry about the questions. We'll put them together,
okay.
And then we'll ask.
Sorry, they just keep popping up. And,
I know.
Yeah. So we will address all that once we come back from the first breaks. And before we go for our first break, I have this question to ask though. I understand, based on a report that was done by CGTN Africa, one of your channels in Nigeria, that one of your facilities has been able to successfully do about 169 kidney transplants. And I think that's a laudable feat. Congratulations on that. But my follow-up question is, has that kind of feat and then other success stories that you've shown help you to start gathering certain trends in terms of health data that would help in policy implementation or advisory? Have you been able to gather enough information, or is that a plan that you have coming up?
So again, like I said earlier, most of what I've been doing this time of COVID has been a result of the sort of data that I've been privy to have as a company and as a company CEO. And I've seen that has really been very helpful in helping the government with some decision making.
right? While on the government, on the business front, we haven't gathered so much data because the traction isn't that heavy. But the learnings that we have, whenever we have to work or contribute to any statewide intervention with the government, we are always able to impute that. So I'll give an example. The Lagos State is currently trying to replicate what we have on the private scale for the state government. Not because they're trying to replicate it. They have a similar idea to do something similar, right? And, you know, joining that task force, the technical working group that was set up for it has helped them to glean a lot of, oh, don't do this. We had this problem when we started. This is not the best way to go. Let's try this way and shorten the time. So I've been able to really create a lot of impact for them. The other thing is that we work on the philosophy called care models. With care models, you can look at a very granular the community at the granular level and say this community's highest disease burden is maternal mortality or is pregnancy-related deaths, which is maternal mortality. How do we redesign their care pathways in a way that would improve the maternal mortality? And essentially, that is the kind of stuff that we are using the data for at this level. To say, majority of our patients from this particular region have these conditions, or majority of our patients on Doctora have this condition. Then we form a clinical committee meeting and say, guys, professionals, you guys are covering these regions and these areas. How do we reduce this by creating interventions? And that exactly is what we've been doing on Doctora. Cascading that to the government level helps with policy. I hope that's
that's awesome. I can clearly see that into the future, because you've done this for about 4 years now. You started in 2016. So in 4 years has been able to get you to the level where you are now giving some sort of direction and advice all the way governmental level. There's only much that you can do from now. So that's a great fit. So my colleague, Kwesi, would be joining us very soon for something exciting that we do every time called the 60 Seconds Down Memory Lane, where he gets to share with us an indigenous entrepreneur either from Ghana or the sub-region. But before we do that, just one quick one. I understand that with services like this, sometimes there is a potential of players on it. In this case, the real estate people who are providing their facilities to you on one hand, and on the other hand, the health practitioners sometimes collude behind and carry out services off the platform once they have been able to engage. Do you see that as a potential challenge, and how would you go about it? And once you are done, my colleague will come in.
Yeah, so that essentially is disintermediation. It's always a challenge. It's always a challenge, and for us, the only solution we have to that challenge is stickiness, right? So to always be one step ahead in terms of the value we provide. As long as the professionals keep getting value from us, even though scenarios will come when they're going to bypass us and go behind us, they will still be on the platform, right? We can, like, the social behavior that was existing before us is that professionals roam. You know, I'm based in this teaching hospital. I will go to everywhere they call me, and as long as there's money, oh, there's money, 500,000 already, come do this thing. I will go. I'll go and do it, right? So I should not be upset if I'm in the business of trying to make sure that patients are able to get professionals directly, and other patients are also trying to get the same professionals. Please, they should go. We are trying to get them buoyant, right? The more buoyant they are, the more people that are going to try to look for them, right? So that we don't consider it as a challenge. We know it would happen. If it's happening, then we've done something good. But what we've seen is that most of those facilities actually contact us because they know we've already agreed prices with these guys. We've done all of that. So if they want to start in the old discussion and all of that with these professionals, is starting from scratch. So I've seen that most of them just say, you know what, we need a specialist. Let's ask these doctoral guys, as opposed to trying to go behind them.
By themselves. Awesome. All right, thank you. So Kwesi, if you can hear me, kindly take it up from here.
All right, thank you very much, Kelly. Welcome everyone to 60 Seconds Down Memory Lane, the segment where we throw light on the lives of some industrious Ghanaians and the businesses they built. Today we have Dr. Kwame Nyaho Tamaklo, founder of Nyaho Medical Center. Taking inspiration from the Mayo Clinic in USA, Dr. Tamaklo set out to establish Nyaho Clinic in March 1970 with the sole aim of creating a modern private hospital equipped to provide the highest standards of healthcare services to the Ghanaian general public. Starting off with one general practitioner himself and 8 specialists from Kolebu Teaching Hospital, Nyaho Medical Center today operates with 6 general practitioners and over 30 regular specialists. Dr. Tamaklo passed away on November 1st, 2001, passing on the management of the center to his wife and eventually to his son, Dr. Elikem Christian Tamaklo. A pioneer in the provision of private healthcare in Ghana, Dr. Tamaklo earns his place among great entrepreneurs to have emerged from Ghana. That's all for today's session, but before signing off, I want to remind you, like always, stay home and stay alive. You need to be alive to build something. Thank you very much, Kelly. I hope I was within the 60 seconds range.
Yes, you were, Chris. Thank you so much for that insightful session as always. And Nyaho, we all know, is a place of excellence, and I think it's a very good example to emulate when it comes. Sami, if we don't, we go to the STEM in Nigeria. We don't have any questions so far. So welcome to all those who are not part of us before we started the discussion. We are having an interaction today with Dr. Sebo Odulanu from Nigeria. He's the co-founder of Doctora. Doctora is a platform that connects certified health practitioners with health facilities that need their services in connection with patients as well. Doc has been taking us so far through their model, the problems they are solving, and how far they've come so far. Feel free to drop your questions in the chat box and also drop comments as much as possible. We would definitely come to them and share with him. Doc, now let's zoom a bit into the...
Hey, Kelly.
Hi, Sami.
Yeah, there are questions. Sorry, I think I wasn't hearing you. Yeah, so let me just quickly drop 2 questions and then you can take over. Nice. All right. So, Debo, first question is around. This question is from Josephine. Josephine is also joining us all the way from Netherlands, and so she's asking, considering the impact of COVID-19 that is being felt by everyone else, you know, especially by rural folks as well. And also, I mean, in general, rural folks have limited access to healthcare. How does your platform meet the needs of rural people, or do they belong to your target market? She's asking, and as well, she's asking this because it appears your platform uses internet, and you know, in general, a lot of people living in the rural areas don't use internet. You know, so are you reaching them one way or the other? And how do you circumvent this no internet areas? And the second question was, I think the second question is more on a lighter note, that is asking, why did you, what inspired you to choose Doctora as a company name? Yeah, so these are your questions.
Okay, so second question first. Like I said, I went to med school in Dubai. The term doctora is used very loosely in the hospitals. So when an Arab person or is trying to call a female staff within the hospital, they typically would call them doctora. And yeah, when I was trying to figure out the name, that just came up as on the list. When I kept sending it around to people, it was the only one that people kept canceling. So I took that one. Yeah. For the first question, yes, the rural population is on our map. It's not on our map now because strategically it is really difficult to build a business model that would be sustainable at this phase of our business. We hope that as we progress and we're able to get, say, a bit more donor funding or some grants, we might now be able to go in there to create solutions for them. Again, the solutions have to be geared around the difficulties in those areas. And what we're doing so far, for example, now that there's COVID, is that we've shifted most of our activities to telemedicine. And for us, telemedicine goes from USSD to SMS to voice to video call. And to the extent of even having assisted telemedicine, where you would have a community health worker or another community representative or professional that would be the intermediary between the doctor and the patient. This is because most doctors would not even go to the rural areas. We can assume that maybe, yes, we can take them on rotations and say, oh, we'll go in this week and then we are coming back again in 2 months. But that will really be for people who really want to have fun and want to go and do some real giving back. For those who are not in that category, they can sit in the city and know that, oh yes, on Tuesdays between 5 p.m. and 10 p.m., I review cases from X village. Then I review cases from Y village. What we now need to do in that X village or Y village is to figure out, is there a center in this village that we can put SATCOMs or some sort of internet service provision there? Typically an existing primary healthcare center, that we can go into a private-public partnership with the government to take over, renovate, and create telemedicine booths, because we need the patients to be able to come into a place where there's internet to connect with the doctors. The next is, most of these places where there's no internet, there is mobile connectivity. They can have their mobile phones. So with that, we would use audio calls. Now, obviously, the limitations are extreme and a lot. So we just have to keep building around the limitations. And we know that by the time we invest in rural healthcare infrastructure in a way that it fits into something technology can kind of accentuate, then we will gain a lot of gains from it. That's our plan for the rural area. Again, that would not work without any insurance plan for those people. So we would also be looking at getting to the level where we are also now an insurance provider or a conduit for other insurance providers to now start going to those regions now. So if I can go to a rural area and sell them 500 naira per head for the whole village, then I know I've covered the whole village, even though my coverage for them would be low. We are doing something like that for the markets. So the markets normally have association. We go, they pay X amount monthly. Then we go into their market. We open a small clinic in the market, and then we give them basic healthcare around. That's the vicinity.
Awesome. All right. Thanks. Questions, and so I'm going to be as fast as talking about the Nigerian startup ecosystem. But then I'll start first of all from you yourself. You are quoted to have said that capital finds those who need it. I don't know what inspired that thought, but I just wanted to find out from you, how was it like financing your startup from the onset for yourself?
Yeah. So, like I said, again, yeah, based on that philosophy of capital finding. Hello?
Hi, we can hear you, Doc. Go ahead.
So based on the philosophy of capital finding the businesses, I knew what I really needed to do was to demonstrate the value my business had to show.
And I guess that's the continuous journey of an entrepreneur, to keep figuring out how, you know what, I have this idea, how do I turn it to life? How do I show that it's bringing revenue? How do I show it works so that investors now want to give me money to build it? Yeah, and that's exactly what I mean by capital, always seeking the businesses that need it. And the first form of capital, as I was taught in, and the best form in business school, is revenue. So when you actually sell your goods to the customers, who really need the value the most? So investors need a different type of value, but the customers need the real value. As long as those guys are paying for it, then you've demonstrated that the solution is of value. So based on that, what I did was I built the first website myself. I did it on Wix. That cost me about $300 plus, just roughly $400. Then I, after launching that, I did free consultations for 2 months. So we gained some, you know, some traction in terms of people just actually realizing that this guy's actually serious about the stuff that he says he wants to do, right? Then I went on top of that and did a GoFundMe campaign with my classmates at uni. That didn't do a lot, but I was able to get about £500 or thereabouts from that. Then my co-founder Beatrix added another £500. I added 500. I added £3,000 actually. Then my other co-founders put in some cash, and then we just kept using the cash to do different things. We shot some videos, had some adverts, and then got into incubation program with CC Hub. After doing this GIZ accelerator program in Lagos, the Make IT program, then, you know, with the Make IT, we got more traction because of the exposure and everything. So from that point, we had started generating revenue, and we had started doing enough to get some grants. So we also got the Tony Elmelu grant. We got a few other grants. Till now, we've gotten grants close to 15 million naira. And that is actually more than actually what we've raised from external investors. To date, we've not raised more than 30,000. Actually, in cash, it's $25,000. The rest has been between myself and my co-founders. What I did in terms of facilities was I went to family and just said to an uncle, please, I need this facility. This is your building. Can I use it for 2 years? I'll pay you at the end of the 2 years. He's like, okay, why not? No problem, go ahead. Then I went to my, I have a building of my own. I converted it. Then I converted my apartment as well. And then with that, people could see what I was talking about. It wasn't just, oh, the idea, whatnot. Because when we first went to the hospitals, they turned us down. They said, no, we weren't interested. So we set up our own facilities, and then they now became interested because they saw what we wanted. So that was the journey, and that's how we got the funding so far. So it's been a case of, you know, sometimes I still put my hands in my pocket and put money to pay salaries or whatnot. But, you know, like, we've not been able to grow the team as fast as we want or get the right kind of people. We're pushing it. It's despite collecting money from some people type of scenario. And we're looking to ways now that we know that it's time to scale up. And for me, this is the right approach to things, because if we had gotten, say, $200,000 2 years ago, we would have skipped a lot of growing pains and used money to fast track a lot of things that really shouldn't have happened. Now we're in a position where things are actually gradually seeping in. The brand is going in. The HMOs are calling us because nobody wants to go to hospitals. So we are gaining ground of the things, and it's a good position to be. Now, investors are also feeling comfortable enough to say, yes, we agree with your valuation. Here is some money. Let's see how you can grow this and go to other African countries.
Yeah, and I think that's very admirable. The fact that you've been able to sell the idea to right from family to friends to other external people. Now investors are buying into it, and you yourself had to do some sacrifices as well. So I think that's a good example. Now we've run almost out of time. I would encourage that everybody who has questions for us, still drop it in the chat box. If we are unable to answer them today, all we are going to do is put all of them together, share with Dr. Debo, and then once he responds to it, we are going to put this on our social media platforms, and you'll be able to get your response over there. I wanted to ask a question. In Ghana, we call something Apo. Apo is when you leak a question to somebody before they get into the real exam hall. So I wanted to find out from you how Nigerian startups are doing so well that they are attracting a lot of investment. You mentioned earlier on about InterSwitch being one of the typical unicorns in Africa. You can talk about Jumia and all the other ones. Just briefly, in 2 sentences, what is the secret formula for Nigerian startups to attract a lot
of packaging.
Mm-hmm. I would definitely laugh to that.
Yes, because if you look at it, the packaging doesn't work. It doesn't work for the Nigerian investors or for the African investors, these Ghanaian investors. There's the packaging for the foreign investors, and those ones they chop it. They just swallow it, you know. And this packaging, and the major part of the packaging is when I come to you and I start to quote market numbers. We have numbers. We have 200 million people. By the time I drill it down, I can find 130 million, 120 million people that will pay, that will do this, that will do that. Obviously, me, that I'm in business, if somebody comes or as a Nigerian investor, or someone who knows the system here in Africa, someone comes to me and starts to give me all those numbers, I'm just looking at him like, yeah, what is the real effective demand? But if I'm talking to an American-based investor who is seeing my metrics, and the metrics is seeing are showing that 100,000 people have paid X amount of money. And this guy is telling me that, and this X amount of money is like maybe 100,000 people have paid subscription of 1,000 naira each. And this guy is telling me that there are 100 million more people that can pay this 1,000 naira. Oh, let's do this. He has no clue how difficult the cost of customer acquisition, all of that, to reach 1 million users or 100,000 users or thereabouts. But this guy that is just showing revenue numbers, I'll give an example. A company raised a lot of money from YC. They had over 60,000 users. They were in Ghana, they were in Nigeria, they were everything. But their users were not paying money, right? But with 60,000 users, they kept packaging this. We have 60,000 users. We're a market size of this. We got these 60,000 users within a 6-month period, which shows that these people really want our service. But are these 60,000 users paying you money? No. You understand? But the investor is seeing 60,000 users and potential to go to 6 million users. And these guys did it in 6 months. So they should be able to do it if I give them money. You understand?
Yeah.
And that is exactly what's happening.
Yeah.
So it's the packaging. All right. I think we've got a secret formula now. We are going to work on it. We obviously can't be 180 million in a year's time, but we'll probably find a way of doing it.
You can invite other people from other African countries.
I think maybe we should do that. All right.
So
actually, that's a good one. We probably need to do it again. I had a number of questions, but we are running out of time. So we are just going to end with something that we always do with all our founders. We call it the founders tip, where you share with us in just a line, all right, just one brief sentence, what your entrepreneurial journey has been so far, and what lesson you've learned that you want to share with people, just briefly in one, which you will be quoted on later on.
Okay, so I would say it's really been an interesting entrepreneurial journey. Interesting because down to family, despite the fact that I convinced them, till now, they still, some members of my family still wonder, what are you doing? You know, and they can see the value. They can see that things are falling into place and whatnot. But, sometimes it would really, really be tough, and it would seem as if things are not working. But you really need to, if possible, document the little wins, maybe on a board, and see how those little wins contribute to your end goal. Because if all you achieve in Q1 of this year is that you have been able to speak to 10 HMO CEOs and hear that they've told you why it will not work, then you can go and write on your board that 10 HMO CEOs have told us that this model will not work. It's not a loss. You've not lost. You've actually gained. You've learned something that wouldn't work, right? So that sort of approach and being able to keep moving, you have to be fluid. There will be obstacles. We need to make sure that we are ready to move around those obstacles and be as fluid as possible. The greatest problem any entrepreneur can have is to be stubborn and just feel that your idea is the best thing since sliced bread and it's the only way that can work. You have an idea. You just have an idea. There's a problem. The people that have the problem are the ones that know the best way to solve their problem. You need to work with them. You suggest your idea to them and get their feedback. And then as you keep going back and forth, you will probably get something that can work. It's that thing that can work that is the real solution, not your idea. So that essentially is what I would say to people. Just keep at it and don't get discouraged, really. Don't get discouraged. Everybody, every single person, including the people that tell you, this is such a great idea, they probably don't want you to. And they probably don't think you can make it. So just keep going. Like you would show them that you can do it. Every day I get people that contact me and say, hey, you are still at this thing. I saw you on the news. Wow, I didn't believe you still be at it. And I'm just like, yeah, I know you didn't believe I'll still be at it.
Thank you so much, Dr. Debo. This has been a very insightful session. Lucy says she loves it. To be stubborn, that's one of being stubborn is one of the things that an entrepreneur shouldn't be doing. So thank you so much for your time, and I appreciate that you were able to join us. And even more importantly, I appreciate our guests and our host, and our audience for joining us today. It's been very insightful. And before you go though, quick one: what does Debo mean? If you could just give us a little.
Debo is short for Adebowale, as you can see on my screen name. Adebowale it literally means the crown is back home. So it's typically a sort of, the crown is back home. So I come from a ruling family, and in my village there are 5 ruling families. So the crown rotates between those families.
Awesome.
As I was born, it was due to come back to us.
Thank you for bringing the crown back home, and even more importantly, thank you for bringing.
We're trying to bring healthcare back home now.
In healthcare. So I am quite excited about this idea because I think it is said that a wealthy nation is one that has a healthy population. So if you're able to do this and do it so well and expand it across the sub-region, we are just going to be assured of a continent that is very healthy. Thank you so much, and thanks to everyone. Before we go, I have been your host today, co-hosted with Sami and my colleague Kwesi on the other side, as well as Sahil, who you didn't get to see. But what we are going to do now is ask everybody to turn on their video, and Sami is going to take a quick snapshot. This is what we always do with our tradition for the event. So just turn on your video quickly. We take a last photo, and then we will be done for the day.
Yes, so group picture, give me your nice smiles. Yeah, and thank you all for joining. Yes, really, really nice smiles. If you don't want to turn on your video, that's fine. So I would just go 1, I'm taking just 2. So 1, and then we have 2. All right, thank you guys so much for joining. Yeah, and then we really appreciate you guys, and see you next 2 weeks as well. It's going to be another amazing one. Thank you, Debo. We really appreciate, and we pray that you keep going, and then let's make Africa happen. Bye guys.
theater, you know what you're shown. Nagbe wa, you know, via Siri, you know, Padi Keteku.